The term digital health is used very loosely to cover a lot of different things that have to do with information technology. And don't forget, I mean, IT has been around for a long time, right? I mean, we're in the fifth decade of IT in everyday life. To me, that's probably the most important element that most people are after in this so-called digital health, which is, providing patients with an easier interface with the healthcare system. So if you think about where digital health is compared to the rest of your digital world, you pretty much interact commercially with everybody without talking to a person. But health systems haven't opened up to open scheduling. They haven't provided people with information as to how to access them properly. And so a lot of digital health solutions are trying to tackle that, either through things like care coordination, information gathering, payment solutions. I mean, there's a lot of it. In my mind, probably the most important aspect of digital health is the patient-facing piece. That's just my opinion, but I think that's where you're seeing a lot of attention.
So what I would hear for other people's expertise regarding the perspective of there's a digital front door for large systems, but then also the smaller systems, and how that fits into kind of like the consumer disruption that's going on right now. So in the smaller systems, like I can give you examples of digital health tools, that people have developed, such as Fruit Street is a company that has developed like a consumer-oriented digital health tool, and it's a really good example of a system that has worked through kind of the virtual health and the digital care solutions. And so that integrates in with the virtual environment. But some of these digital health tools, there's tools designed for the smaller systems and then for the larger systems too, which are more sophisticated. So I think it gets to who's leading a lot of the initiatives. So, like with Fruit Street, for example, there's a team of people, and like physicians are kind of investing in the company. They're investing, so they're committed and they're showing support for the initiative. Locally here in Michigan, where I'm currently at, they have a lot of solutions they're offering through the health information exchanges. If you have the virtual care, then the digital health becomes a lot more feasible or possible.
I keep coming back in my mind to something that Mark said earlier about what is digital health. And it's just I don't know what that is. It's just such a big, broad, encompassing term.
How about why there's such differentiated adoption of different solutions based on where you are and the location? I mean, one solution we could point out there is that it's all about the management team, that if you have a bureaucracy that's not willing to adopt innovation, then you're just SOL. But when we try to blame everything on this microstructure, then tell me why. So you're telling me that 40% adoption of solutions or whatever in an easy day is because 60% of the management teams in America suck?
Let's be clear. There's not a lot of evidence that a lot of these solutions make a difference, right? So typically in healthcare, we demand, if we're going to change practice, at least theoretically, that we want some evidence. We want to prove that something changed, that a health outcome was improved. I mean, and so, that's my first point is there should be a healthy amount of skepticism on the part of health systems who have lots of things to do and lots of, challenges to be able to just simply say, we're not ready for this because we're managing patients reasonably well. And it's not clear to us that you've proven through a randomized controlled trial, which is, what's basic scientific method. Your enthusiasm as an entrepreneur and innovator and your, promise that this is going to make a difference, it just doesn't cut it. It's not enough. So we need kind of, either clear science, or we need our patients telling us that this is really going to help them and they want us to do this.
Go
I
ahead,
think
Kate.
that's a great point from a perspective of, I agree with you 100%. There are many digital health solutions out there that don't think that they require any data or evidence. And one of the things that Mike and I talk about when we're with them, we're like, oh yeah, you do. Like, where is it? You have to have that. These are for the most part, again, well, if you look at physicians as a whole, these are analytical minds that want to know that this is going to make things better for their, statistically significantly better for their patients. I think on the other side of things, though, just coming from an operations background, so again, one large integrated healthcare system, like the consumerization or consumerism aspect of healthcare, the patients are demanding it. They are pushing for the ability to book their own appointments. And what I saw, at least in my own organization, is providers do not want to give up. Again, I think provider autonomy and the ability to have some control over their schedule and what ends up in their schedule is a very difficult thing for providers to give up. Because when you open the schedule up, if we just take that as an example, when you open the schedule up, you have patients that no matter what, they want to be seen, and whether they need to be seen or not, they are going to get an appointment. And then you have the patients. So those are the patients that want to be seen. And then you have the patients that need to be seen. And how do you make sure, again, from a provider perspective, and I realize I'm primary care, not specialty care, but specialty self-referral is something else that we tried within KP for a period of time. And Mark, you would have had patients in your schedule that had something ridiculous like Osgood-Schlatters disease or something. They did not need your help or support. They needed to see their primary care doctor. And that pisses off the specialist more than anything. But the same thing with primary care physicians. They don't want, at least in my experience, again.
Oh, right. Open scheduling.
That need
Right.
to be there. In their
Most providers do not want open scheduling for the reasons that you describe, unless they don't have much business, right? And
Right.
So, so busy, skilled clinicians who have full practices do not want open scheduling.
We're talking about different buckets of digital health, right?
Mhm.
So, Mark, I think you mentioned earlier, patient engagement, clinical support, right? All of that, certainly clinical support, you're going to need the clinical outcomes data to show that it makes a difference, right? But scheduling, back office operations, billing, reimbursement, all that stuff. Yeah, there are digital components to that as well. And that's something those adoptions are driven more by ROI and workflow improvements, right? So I think, it's helpful, at least in my mind, to wrap my arms around this, is to figure out what buckets digital health falls into. Each bucket will have different competitive dynamics, different demands for adoption. And of course, even go further upstream, is there a market there, right? I mean, is an early startup company going to get funding if there's not a market there? And I mean, it's just a large expanse of digital health. I think you need to focus on individual buckets.
I think there's reimbursement now with coding that exists now that wasn't available previously. So as long as you have health plan coding that somebody can do something with, there's going to be so you'll either break even versus have some sort of profit. A lot of times, like the setting that I worked in back in 2006 was a diagnostic testing center, and so the way they're structured is there's technology combined with traditional practice. And so the traditional practices like primary care may not be able to have a profit from it, but in diagnostic testing centers or some of these for-profit physician hospital organizations or surgery centers, are the places where inherently the devices are housed and people use them as like real world evidence laboratories.
Well, I mean, I think that the basic function of digital health is to convey information.
Mm-hmm.
I mean, the basic function of healthcare
Mhm.
is information exchange,
Mhm.
right? Like when a patient comes to see me, right? I mean, we're going back to the fundamentals of medicine, which is, a physician-patient encounter is really about me taking a history, right?
Mhm.
Making a diagnosis,
Mhm.
and then providing the information back to the patient about what they should do or what I can do, right? And in some cases, there turns out that there's, a physical piece of it, whether we give them a pill or do surgery or therapy, like there is something that we actually do to their bodies. But, fundamentally, when you think about what is medicine, medicine is an exchange of information,
Mhm.
and then sometimes an exchange of some kind of intervention. And so it doesn't matter to me the setting. Back in the old days, we would just write it on a piece of paper. Then we said, well, we're going to digitize healthcare, and we created these EMRs that really didn't digitize it effectively, but it did create some ability to search and some ability to aggregate. But it wasn't patient friendly. Those were meant, they were meant for something else. And so now we're trying to recapture that, right? And try to say, okay, can we make it easier for patients to provide their information to us and for us to educate them and provide them information in exchange?
Would you not agree though? So I think, you can think of it if you look at the patient journey, right? Beginning to end. Part of this is what is home care and self-care, and what are the digital health tools that actually can help patients before they even interact with the system? I guess I would look at it, right? There are tools that would allow them to do many things on their own, so they don't actually need me. I would hope that's the case, because there is a lot of stuff. Again, I'm not a surgeon, but there's a lot of things that
there's social factors, right?
Sure.
I mean, this goes into a broader discussion, like what is healthcare, and does it include my, heating system in my house?
Well, I think it actually goes to what is digital health,
Right.
because there are patient-facing tools. There are, sure, access to care and information transfer types of tools. There are hopefully tools that are going to improve efficiency, diagnosis, treatment algorithms, all of those types of things. I look at all of that. And then what are the tools on the back end? So I've treated this patient. What are the tools on the back end, again, that are going to hopefully keep them moving in the right direction on a path to recovery or health or whatever path we have sent them on, that again can help support them in that part of their journey. So I guess I look at it from beginning to end.
But I like your comment about the home care. That's a good dimension, because that's huge for digital health and people don't think about it. So,
what I ask, entrepreneurs is kind of, how would I measure the impact of your intervention? Right? Like, it kind of goes to what we've been talking about in other contexts, with like OKRs, like what's your objective? And, what are the key results that we're going to see that have to happen in order to achieve those objectives? And the problem,
let's
in
assume, Mark,
healthcare,
that we do measure these things. Like, for example, we've seen a lot of companies, Katie mentioned earlier, we often quiz and grill the company, particularly those that are patient facing. Like, I have so much skepticism about most of that stuff, because they're also excited about their solutions, like prove to me that it's being adopted. So they have measurable outcomes, and yet people still don't want to adopt it. Sometimes it feels like middle tier, let's call middle tier adopters, right? Like the brute group of people that need to create critical mass feel this risk if they implement a new solution, and even if it's better, that they're somehow going to get blamed for not adopting it earlier, or there's some weird kind of dynamic going on that I don't understand, that maybe you guys can give me insight into.
I think that what happens is, whatever problem that solution is solving just may not have that much importance to that healthcare system. Okay, so I mean, I tell, entrepreneurs to make sure they understand that what the CEO of the healthcare system, if it's a system or practice, what keeps them up at night? What are their key initiatives that they're talking to their board? if you have a customer that's, the Cleveland Clinic or the Mayo Clinic, have you read their annual report and know what they talk about as, what's important to them? Because, you better have a straight line or a dotted line to their key initiatives that they talk about to their board. Otherwise, they'll say, yeah, that seems like a great idea. But they're so busy doing so many other things. There's only so many priorities that a healthcare system can adopt at any one time. So that today, that nobody gives a shit about digital adoption. What they care about is they cannot find enough nurses. And so every conversation that's happening in the boardroom of a health system is, what are we doing to support our nurses? How are we hiring them? How do we reduce turnover? So I've coached a couple of CEOs and had them reframe their whole pitch. But my point is, not to get too down into that rabbit hole, but to say, look, you should know what's keeping people up at night and craft your pitch to how it's going to impact it in some way. And then you'll get the adoption, Mike, that you're talking about. Because if you're just saying, oh, this is going to improve X, Y, and Z and, blah, 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 that may be great, but I'm busy right now because I got a workforce issue.
Sort of been itching on that point. We have seen the enemy and it is us. The whole reason when you start interviewing people, nurses, physicians, whatever, the burnout, the frustration is the digital aspect of medicine. That's what's driving us all nuts. And that's what's driving inefficiency, through the roof or efficiency through the floor.
Perceived, right?
What's that?
Real or perceived inefficiency, I would say.
Oh, I say it's real. I mean, compared to how things were before this, and I know that EHRs are a necessary evil, and with the compliance issues and all that, we have to do it. So it's actually circling back to make technology more efficient, more relevant to what we really do. I mean, how many times during the day do we sit here and check a bunch of insane, moronic boxes? There's just a bunch of legalese and doublespeak that has no relevance whatsoever to what we're doing. We're not looking the patient in the eye. We're not, the patient perceives us as just poking around on the computer. And, and I think your point was to go out and, talk to these folks about what their needs are, and then trying to come up with a solution for the problems. Instead of having a really nifty idea and let's go try to talk everyone into adopting, our Q plan for our idea to solve some problem we think is important. And I can tell you, as a practicing physician, as an owner, and also a hospital board member, we're inundated daily with companies out here with digital solutions for just a myriad of issues, and you're overwhelmed. It's like the stupid non-steroidals. How many more non-steroidal anti-inflammatory agents do we really need? And that's how I view it. And you get numb. You just get numb after a while.
We are practicing medicine measured up against the standard of care, somehow replacing my clinical judgment or my face-to-face visit with a patient with a digital tool and or a different way of doing things. Am I meeting the standard of care? I definitely think, I would say this was not the case for me, and I actually love the ability to interact with my patients without having to see them face-to-face. But I think there are a lot of providers that really have this hanging over them, this risk or fear of malpractice or being sued, and that transition to a digital tool taking the place of something that I used to do myself. I think there are many providers that are fearful of that from that perspective.
Yeah, but I want to come back to what John said. We've all been burned by terrible technology. And look, I just got a new Sonos speaker, and it's kind of like the old Mac model. You open the box, it goes, here's 1, 2, 3. This is all you have to do, and it's It's up and running within 45 seconds. And you show me a healthcare digital solution that does that, right? Like this is complex technology. You know, Sonos is a very interesting system, very complex, but your Mac was always the same way. Open this first, do this, push this button, and you're done. You know, when you go to implement a new EMR, it's like a 1-year undertaking for a health system. It's like ridiculous. So a lot of the problem is in the solution providers. You know, Jeff Bezos said in Amazon, if Alexa doesn't respond with an answer within 2 seconds, it's dead. Okay, 2 seconds. And so like we just aren't holding our digital health solution providers to a high enough standard to get into healthcare. And that's why there's such a burden that John describes with in the clinical domain. It's a muckety muck.
And I would say there are two aspects of that, right? I mean, you talk about your experience as a consumer. So there's the patient facing experience. If this does not make my ability to access care or get the answers that I need easier. But on the other side of it, I would say, I mean, in my role within KP would harp on no, wait a minute, you're making the provider care team, you know, you're increasing the amount of time and or clicks or whatever that it's going to take to do something.
I'm talking about this from the provider aspect as well. If you
both sides, I think.
Yeah, if you introduce this into my clinic, this better be turnkey. Like it better be almost instantaneous. And
improve my efficiency, not just the implementation, but make it easier for me to provide care.
Yeah, 100%. And I think it's doable, and we're starting to see solutions that do that, but they've been, you know, they're having a hard time getting in because people have been inundated, as John said, with a bunch of garbage.
It is a crowded space. Getting providers to do things differently is very hard. Whether it's going to make their job easier in the end or not, Mark, to your point, like if it is not, I turn this thing on and it is instant, the instant gratification, right, that our society demands right now, if it is not right there, they're going to say, nope, this is too hard. This is too much work. Why would I change my behavior to implement something like this?
So just if I could hop in just a couple points. One, we're beating up technology a lot here. Right. And that's fine, but just in all fairness to technology, you know, in the field of radiology with the advent of PACS and RIS systems, I mean, hey, that's been fantastic. When I started my career out, we were hanging films on alternators, right? And that's history. Films are history, right, for the most part. So technology has enabled us to get prior reports, prior studies. It doesn't always talk well together, I certainly agree, but it has been useful. You know, the analogy of the Mac, I think it's a great analogy, but we're not just talking about Macs or PCs. You could pop on a Mac or PC, whatever your favorite machine is, and it's intuitive, but we're talking about the technology that resides on those and multiple nodes of those and networks of those. You know, my experience with them, these are complex systems that go across the enterprise and are trying to bridge multiple enterprises to pull information over so that wherever I walk into in the United States, my information is there, whatever facility. So I think the scale is significantly different.
I agree with you, but I also would say that like we marvel at the PAC system, right? Like that we could get digital x-rays as though that's like an amazing technology. But I can pick up my phone and get any movie ever made like instantaneously. Like technology is advanced and healthcare lags no matter what we say. And we're always mysticizing. I mean, I think all of us clinicians are guilty of the single biggest problem in healthcare, which is the mythology of medicine. That what we do is so much more complex than anything else, that what we do is inaccessible to our patients, that what we do is harder to solve than all these other problems. I personally don't buy it.
People would disagree with that, by the way.
So it's more regulated, right? So you know,
it's not more regulated than most other industries. We say that.
Well, but it's easier for us to get Netflix, and that's regulated, but there's no HIPAA there. And if you're pulling up Netflix, you're pulling up some information or some.
Probably the banking industry, though, would be the best, I think, comparison to healthcare. And they have been able to make huge advances in technology.
Yeah, so I wanted to talk about regulations. One of the things I was going to bring up, but yes, I can say that compared to financial data systems and regulatory controls and security and privacy issues, the medical community has it easy. Like we have, like, to your point, we've mysticized this concept, like, oh no, they're paper records and they're in this file cabinet and this type of picture, and films versus digital records and blah, blah, blah. That is nothing compared to comparing like third tranche securitized notes with this type of amortization schedule and all of this contractual obligation to this structured product over here, to equity derivatives listed in Hong Kong, to all of this over here. And yet we're able to pull all of those into a single risk system, right? So it's taken a long time. 20 years ago, we couldn't. 10 years ago, we were struggling with it. Now they can.
But the interesting thing about financial information and healthcare information is, go to a cocktail party and everyone will tell you what their medical problems are, but none of them will tell you how much money they make. Right?
Or anything else about their financial situation.
Right. Like, so people's financial privacy is much more important to them than their health privacy.
That's true. Saul, I think you made a good point. There's a place out of Nashville that's called the Center for Healthcare Interoperability. And part of, this idea that systems and even just equipment across, different manufacturers do not talk to one another, and then integrating those with EHRs, et cetera. Like, there's a big issue on the interoperability front, I think, across the board.
I would argue, Sal, that healthcare has been under-regulated, so that we're like the railroads, that we don't have a track gauge that we agree to. And so, the kinds of regulation that have existed in healthcare have been the wrong kind of regulation. And they've done what John described earlier, is just make us do stupid things like check boxes instead of just actually regulating the industry, how it operates.
When you say regulate, so regulate what part of the industry?
Like, interoperability was an issue, 15 years ago, and it still, hasn't been solved. Right? Like, that's a government thing.
So why hasn't it been done?
If you want to know the strongest lobbies in Washington, right? Hospital lobby, right? The pharmaceutical device lobby.
Mm-hmm.
These are the most powerful in the insurance industry. Even today, like this transparency, right? This move towards price transparency in healthcare, they're all fighting it tooth and nail. Can't be done. Can't be done.
Has to be done. We will not get any change, reduction, improvement, cost, quality, any of those things unless we have that, in my opinion. But
I once time had a conversation with one of my partners at the Cleveland Clinic, who was a cardiologist. He read cardiac echoes. And I asked him, I said, so, like, what portion of what you do is a commodity, could be done just as well by almost anyone else? And what portion requires your super level of Cleveland Clinic expertise? And he looked at me like I was an idiot. And he's like, nothing I do is a commodity. And I'm like, okay. I go, really, Brian? Like, everything you do is superior to the guy down the street. Okay. That's a problem. We have to accept that fact and make it shoppable.